I will organize my presentation according to three questions. Who are the individuals with special needs in oral health? Are there inequalities in oral health for persons with special needs? And how should we tackle oral health inequalities for persons with special needs? Public health policies about oral health care and prevention cannot be planned nor implemented without the knowledge of the numbers and the needs of the population concerned. Firstly, a definition of the population with special needs is essential in order to project on the medical, economical, and social consequences of a disease, a deficiency, or a disability. The internal classification of functional disability and health could be used to provide the framework of a definition of a population with special needs in oral health. The items of the ICF could be groups to differentiate three groups that are in need of oral health. The first group is composed by the persons who experience a disability due to the impairment of oral functions and or structure, and who are limited in their activity of participation directly by their oral status. Those persons in most of the European countries have an answer to their needs through the organization of the oral and dental profession. The second group is composed by the person with a health condition that has direct or indirect repercussion on their oral health. Those persons could more or less have an answer, but few European countries have organized their oral professional for these persons. And the third group is composed by the person whose oral health is negatively affected by their social, environmental, or cultural context. For example, recent immigrants, some groups in the overseas territories, inmates, homeless persons, whatever. Thus, the special needs conditions is directly related to the environment of the individuals. And a definition based on the second and the third groups of the ICF items could be proposed to characterize the individuals with special needs in oral health. Persons with a disability or activity restriction that directly or indirectly affects their oral health within the personal and environmental context of the individuals are the first groups. Indeed, not all of the persons who have disabilities are in special needs for their oral health. A man with Down syndrome, for example, could be treated within the mainstream oral services, while some others could not. The second group is constituted by the persons living in a social, cultural, or environmental context that directly or indirectly affects their oral health in relation to the social determinants of health and to barriers experienced in accessing health care and prevention. Despite the etiologic differences behind their special needs in oral health, both groups have identical barriers to the maintenance of oral health. Those barriers can be related to the individual. Individuals may not have access to oral examination, oral preventions, or dental treatment due to lack of cooperation or due to cultural or social barriers. Individuals may have difficulty expressing their oral health needs due to cognitive or mental disorders or due to cultural or social barriers too. Individuals may not brush their teeth and may fail to be reached by national measures of oral prevention due to cognitive or mental disorders or due to cultural or social barriers. That is the case in France for the national prevention program that is supposed to teach to reach the kids from 12 years old. And those populations share also the environmental barriers. The majority of general dentists declare that they are untrained and unable to treat patients with special needs and refer such patients to another practitioner or elsewhere. Appropriate services are not always available, however. For example, not all countries nor locally inside a European country can propose access for sedation nor general anesthesia for those uncooperative patients. Consequently, patients may be left untreated, or if uncooperative, they can be treated under restraint. These patients tend to receive more extractions than conservative care, particularly when they are treated under general anesthesia, because very few countries can propose the access for the general anesthesia room for those dentists who perform conservative care. Caregivers and institutional staff are untrained in individual oral hygiene techniques for dependent persons. Collective measures for oral preventions are rarely implemented. Few countries consider financial cover for the potential additional costs of treating patients with special needs. Consequently, benevolence is the worst things we can hope for this population, because we can't ask for quality nor a systematic approach. Consequences in oral health are worse. Epidemiological data on oral health gathered in French in a control and cross-sectional survey describe poor situations that is compared to the 6-12-year-old children without disabilities. Those children with disabilities have a 4 times greater risk for poor oral health, twice times the risk for requiring dental treatment, and 5 times greater risk of requiring health education and prevention. And things are growing with the child. Compared to the children with disability, the adolescent and young adults with disabilities have 3.5 times a greater risk for poor oral health, 1.5 times greater risk for requiring dental treatment, and 1.5 times greater risk of requiring health educations and preventions. Those results are coming from the algorithmic associations of a set of 26 oral health indicators. Thus, we are in a situation of inequities, at least in France and also in most of European countries. The removal of barriers to oral health are also common for both groups. It depends on both professional reorganization and socio-political choices as well. Some proposal can be made to reduce situations of negative discriminations. Services, systems, and policies aimed at improving oral health for the general population should be applicable to all persons, to all citizens, whatever is deficiencies or disabilities. To all persons, including those with special needs, to ensure equality between populations. These measures imply that universal applicability must be a basic principle underlying the design and implementation of oral health services, systems, and policies. Evaluations of oral health services, systems, and policies must use appropriate indicators that can be applied to all populations. I'm not sure that the ICDAS new score for the CARIS process could be applied to this population. If access to services and systems involves additional costs for persons with special needs compared to the general populations, these costs must be met within the system and not left neither to the individuals nor the families nor to the practitioner. The creation of facilitators to oral health for people with special needs depends on both professional reorganizations and socio-political choices. Services, systems, and policies, again, specifically aimed at improving the oral health of persons with special needs are necessary to ensure equity between populations. These measures imply that oral health promotion initiatives need to be developed that empower persons with special needs, their family and caregiver, and ensure access to oral hygiene and healthy diet. Mandatory training in special care dentistry must be developed, implemented, and evaluated for all dentists, both under and postgraduate, and for all oral professionals in those countries that have therapists or oral hygienists. Appropriate healthcare pathways and specialist services must be developed, implemented, and evaluated to provide care for individuals enabled to be treated in the primary care sector. Finally, research into the determinants of inequalities is required in order to provide evidence-based solutions for special care dentistry. Thus, here we are. We can hope that the barriers will be removed, but it is not enough. The next challenge we have is that the discriminations will fall down, and then we would have at least trends throughout the Europe system to include all the populations with special needs in the oral health systems. And probably, I think that the next challenge the oral health professional and councils would have is that the integrations of oral health as a part of general health would depend on the capacity of the oral health policies and the systems throughout Europe to integrate the populations with special needs. Thus imply that universities, councils, and professionals would be in movement to integrate these ideas. I thank you for your attention.